of Geriatric Medicine Grand Rounds. Before I introduce our speaker, I have some housekeeping items to take care of. This CME activity is sponsored by the Hawaii Consortium for CME, which is a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine. Evaluation forms can be found on our website or by following the link in the chat box. Your comments are very important to the planning committee, so please do complete an evaluation. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Guo has disclosed that she has no relationships with commercial supporters that could be perceived as a conflict of interest. It's my great pleasure to introduce our speaker for today, Dr. Stephanie Guo. She's a critical care specialist with Queens Medical Center. She graduated from the University of Rochester School of Medicine and Dentistry with honors in 2013. She's board certified in pulmonary medicine and critical care medicine. Today, she's going to share with us her experience with trial drugs for COVID-19 and her perspective from the Queens COVID unit. So please join me in welcoming Dr. Stephanie Guo.
Hi, everyone. Thanks for having me. Let me try to share my screen here. Can everyone see the slides?
Yes, we can.
Okay, perfect. So we'll get started. So today I'm going to talk about trial drugs for COVID-19 with some perspectives here, right here at Queens COVID unit. I have no financial disclosures or conflicts of interest. I thought, given the nature of the talk, though, I would have a little bit of a second type of disclosure, which is that I'm by no means an expert on COVID. I'm a lung doc and I'm an ICU doc, so I've been just taking care of these patients along with my colleagues. And I've had the privilege of working with our research team here to help design and run some of the trials here to look at some of the potential therapies. So I just thought I would take this opportunity to share with you all what we've read, what we've learned, what we've experienced. And I wanted to start with some lessons that were shared to me from a mentor from a different front, but I thought it was nonetheless relevant for today. And that is that no one has all the answers. We must keep asking questions. That's how we will lead to the answers. And we should all begin by questioning our assumptions. And why do I emphasize this? And it's because of things like this. So Jeremy Faust is a ER physician at the Brigham in Boston, and he tweeted this back in May. And he said, I recently led 50 patients have some ginger ale. A bunch of them have been diagnosed with COVID-19. None of them died and hence cure. And so this is obviously meant to be satirical, but it really does highlight a lot of the assumptions that are out there, especially perpetuated by the media. So I hope you guys have a big takeaway from this talk is that I encourage you all to question what you read, question those assumptions, and to really respect the clinical equipoise and the analytical process that really has to happen in order for us to get to some of the answers that we so desperately need. So with that said, I wanted to today review 5 potential COVID therapies. This is by no means comprehensive, but these are the big ones with the best data. These are the ones kind of in the news patients are talking about, and these are the ones that we have the most experience with here at Queens. It's going to be kind of a whirlwind of information, but I do hope to provide some historical and clinical context for their use, describe and analyze some of the current studies that are out there, and to share some of the unique challenges that comes with kind of trying to study drugs in a pandemic. Just to start very briefly, we all know this, COVID started in Wuhan, China back in December of 2019. It was declared a pandemic back in March. These numbers were from last Friday, and they're probably already outdated, but worldwide we have over 19 million cases. Here in the US, we've already exceeded 5 million cases. And here in Hawaii, we already have more than 3,000 cases and I believe 37 deaths as of yesterday. COVID is caused by the SARS-CoV-2 virus. It's a single-stranded RNA virus. It belongs in the same family as the virus that caused the first SARS outbreak and MERS. We know that this virus likes epithelial cells, pneumocytes, alveolar macrophages, so it makes sense that it infects the respiratory and the GI tracts. This is a broad strokes of sort of the clinical manifestations divided into major categories based on their pathophysiology. So all those flu-like illnesses, flu-like symptoms, URIs, myalgias, pneumonia, GI symptoms, that's caused by the viral load. Then we know that it causes ARDS, inflammation-induced lung injury, cardiomyopathy, myocarditis, shock, encephalitis, cytokine release syndrome. That's all from this hyperinflammatory state that happens from this abnormal up-ramping of our immune response to the virus. And we do know that COVID can cause micro and macro circulatory thrombosis. Most of the drugs I'm talking about today will be targeting this viral load issue and the hyperinflammation issue. So with that, we'll get started, and we'll start with the rise and fall of hydroxychloroquine. So hydroxychloroquine is an old drug. It was approved for malaria and autoimmune diseases, so we know it has some immunomodulatory and antimicrobial effects. No one will never really know exactly why it was chosen. Most of the descriptive studies came out of China in late January, early February. Most of those studies will read something like this, which is that the repositioning of old drugs for antiviral treatment seems like a good strategy because we know its safety profile, we know about the side effects, we know the drug interactions. And when we have such huge numbers of patients who are infected and dying, then we really have this urgent need to figure out a drug that is safe and that works. So with that, they started with in vitro studies. Hydroxychloroquine did in fact inhibit viral entry into the cells, and that prompted a lot of the earlier in vivo studies. And one of those studies is this French study, which has since become quite infamous, if you will, and so I wanted to walk you all through it. It's an open label, non-randomized trial. So over here you have this French group enrolled 36 patients. They sort of randomly decided that 26 of them would get hydroxychloroquine and 16 would be the control group. Of the 26 that gets hydroxychloroquine, 6 of them would also get azithromycin, and then they would do nasal swabs on them every single day for 6 days, and the primary endpoint was by day 6, PCR negativity. We did know that of the hydroxychloroquine group, of the 26 of them, 6 were lost to follow-up. 3 actually were admitted to the ICU, 1 died, 1 left the hospital. It was unclear if he was discharged or left AMA, but nonetheless, they excluded these 6 patients from the final analysis. So with all the patients that we had left, they look at them and the blue bar is a hydroxychloroquine arm, and sure enough, they had a higher rate of PCR negativity by day 6. Then they added on the hydroxychloroquine and azithro group, and they did even better. And by day 6, all 6 of them actually were PCR negative. And so the authors concluded that despite the small sample size, our survey shows the hydroxychloroquine treatment is significantly associated with viral load reduction and disappearance, and that effect was reinforced by azithromycin. So, of course, we know there are a number of limitations to this, right? For one, they excluded the bad outcomes out of the study arm and didn't include them in the analysis. It was a very small sample size. It was an unvalidated surrogate endpoint because we didn't actually know if viral clearance necessarily has any clinical implications. And there was a lack of randomization. So we know that these limitations do affect study validity. We may argue that in the setting of a pandemic that these limitations are acceptable, and this may actually be pretty promising early data and that it could be the basis of further studies. But the problem was that the media got a hold of the results of this study, and the next thing we know, President Trump was tweeting about it, and he says that hydroxychloroquine and azithromycin taken together has a real chance to be one of the biggest game changers in the history of medicine. And sure enough, it was all over the news. You guys probably have seen this. I was touted as the miracle cure. What have you got to lose? Our president was telling everyone to try it, that it was not going to hurt people. We saw that it was flying off the shelves. All of a sudden, we had a hydroxychloroquine shortage. And even Dr. Oz chimed in and said that there was real promise. And so unfortunately, with all this media response, it really was a lot of noise that drowned out what the experts were saying. People like Dr. Fauci, who said, actually, we don't have strong evidence that this drug works. Fortunately, in the medical community, people were asking the right questions. People were saying, is this a rush to judgment because of rapid reporting and dissemination? And fortunately, a lot of the academic centers wanted to do further studies to really study it the right way against the placebo control. At that time, it was easier said than done because many people actually believed that everyone should be getting hydroxychloroquine and that it was unethical to be withholding such a miracle drug from that placebo arm. But people pressed on, and actually the WHO created its first kind of historic worldwide trial, and it was called Solidarity. It's an adaptive, randomized, open label trial. They enrolled patients, and the subjects were actually randomized to be in one of these 5 arms, a combination of antiretrovirals, hydroxychloroquine, remdesivir, tocilizumab, and optimized supportive care. And the idea is that the sites can actually participate in all of them or just 1 or 2 arms, and they can come in and out depending on the circumstances, drug availability, and then ultimately they will be analyzed as one big cohort. Here at Queens, we believed in following the scientific process, and we also wanted to study hydroxychloroquine on our own. So we created a trial called the Off-Label Adjunctive Hydroxychloroquine Use for COVID-19. That actually, the abbreviation is OAHU C19 study. The credit for that goes to Dr. Banerjee. He's one of our cardiologists. It's an open label but randomized trial, and we used the same inclusion and exclusion criteria that was used by the Solidarity trial, and we also stratified our patients based on mild to moderate or severe disease. And our outcome was also standardized to the WHO. We were mindful of that when we designed the study. And the primary outcome was this ordinal scale. And this is going to come up again later, so I wanted to walk you guys through it. It's a clinical scoring system between 0 and 8, 0 being unaffected, no symptoms, 8 being death. Hopefully most of our patients fall between kind of 3 and 7. And if there's movement of at least 2 points in either directions, that's considered a significant clinical change. And so these were the outcomes that we stuck to. And the idea is that, we may not enroll hundreds and hundreds of patients on our own, but because we use the standardized protocol, our hope is to be able to assimilate our data into a bigger trial. And in fact, places like Stanford and Hopkins have already asked us for our data in order to kind of add it into their trials to be analyzed. So in the meantime, as more studies were coming out, newer studies were being done, it really did dampen the initial enthusiasm for hydroxychloroquine. One of the ones is this VA study that came out in April. It is retrospective cohort study. They included all of the VA medical centers throughout the US, looked at hydroxychloroquine with azithromycin, and the control arm. It included essentially all of the COVID positive patients as long as they had access to their medical records for analysis. And they did a propensity score matching to account for the differences in baseline characteristics. They had 385 patients, only 17 were women, so they were actually eventually excluded from the analysis. The number was just too small. Overall, the outcomes, so the ventilator days, death without ventilator, discharge without ventilation, those were all about the same. But what was concerning was that they found for mortality, there was actually an increased percentage of death in the hydroxychloroquine arm and a decrease in discharge also in the hydroxychloroquine arm. So the conclusion was that it didn't seem to work. It may actually have harm. This is a specific patient population, right? All male VA population. So that may introduce bias, and it's also retrospective, but it's definitely something to consider. And I think the highlight of this study is really to emphasize that we need to have ongoing randomized control studies before we start widely using hydroxychloroquine. And sure enough, just the next day, another study came out, it was published in JAMA. It was a Brazil study looking at the high dose versus low dose chloroquine. And just kind of simplify things, but down here you can see in the high dose group, actually, they had a 39% 13-day mortality, and many of them were dying from arrhythmias. So they also concluded high dose chloroquine really not even safe to give to patients. Even in low doses, we really should be careful with QTC monitoring, and if we're giving drugs, concurrently giving other drugs that can prolong the QT. Next was this LANCET study, adding more to the data that we have. At face value, this was a very exciting study. It's a multinational registry analysis. They actually included over 96,000 patients between December and April. And when they did their analysis, they found that hydroxychloroquine was associated with a decrease in in-hospital survival and an increase in ventricular arrhythmias, similar to that Brazil study and the VA studies that we've been seeing. So obviously very concerning findings. At the time, some independent reviewers were questioning the methodology of this study, but so it was kind of concurrently being verified as all the results were shared with the public. And sure enough, the Solidarity trial, because of this, paused their hydroxychloroquine arm. They had some safety concerns. Then about a week later, they resumed their trial, and they said that they actually did not find any reason to modify their trial. It was a little confusing for about a day there until the next day, Lancet actually published a retraction of that multinational registry analysis. So as it turned out, Surgisphere was the analytical company that was doing their data analysis, and they were not able to provide their database for independent review. So it really called all of the results into question, and so they ultimately retracted the study. But because of all these different smaller studies showing potential harm, the FDA did revoke the emergency use authorization for hydroxychloroquine on June 15th, meaning that now the drug is only restricted to use in the setting of clinical trials. Since then, there's been Sorry, PowerPoint is stuck. Okay, sorry about that. Since then, there's been just a lot of back and forth. So Solidarity ultimately stopped their hydroxychloroquine arm because of futility. The NIH then stopped their hydroxychloroquine trial because of low enrollment. Not surprisingly, with all the drama in the news, I think a lot of the patients were unwilling to participate. Then at the beginning of July, Henry Ford published a retrospective study that again showed a mortality benefit with hydroxychloroquine. Again, back and forth, the Brazil group published something in end of July in New England Journal looking at kind of milder patient populations, and they showed that there was no difference in the 15-day outcomes. This is a graphic of the ordinal scale that I mentioned, comparing the 3 arms in the study. Again, no significant difference. So where are we at now? Hydroxychloroquine is restricted to only to be used in clinical trials. Some are still enrolling. Since then, we've also found that in vitro studies showed hydroxychloroquine may actually interfere with antiviral activities of remdesivir, which I'll talk more about remdesivir, but FDA warned against the concomitant use of those 2 drugs together. And what's happening at Queens? Well, our OAHU C19 trial is still enrolling. We felt like our questions haven't been answered yet, and we haven't met any of our safety or futility endpoints. But we are excluding anyone who plan to receive or have received remdesivir because of that interaction. And honestly, we don't have that many patients who are not getting remdesivir, so our numbers have been pretty low. So overall, not a satisfying end. We are still waiting for more information, and so stay tuned. All right, next up is the redemption of remdesivir. Hopefully this is a lot less controversial. So remdesivir is a adenosine nucleotide analog prodrug. It targets RNA polymerase. It was actually developed by Gilead Sciences in 2015 as part of the antiviral efforts against Ebola. Long story short, it really did not work for Ebola. This was published in the New England Journal looking at a number of different therapies for Ebola. All you really need to know is that the cumulative incidence for death is in the y-axis, and this blue line here is remdesivir, and it's on top for all 3. So it really did not work. But the good news out of these studies was that we know remdesivir has good activity against several of the respiratory RNA viruses, and we know that it has a favorable safety profile. So it made sense that when COVID was discovered that people wanted to test remdesivir for it. So started in vitro studies, it did seem to have cellular inhibition. Then they started testing in infected rhesus monkeys, and it showed that at least in monkeys, they had clinical improvement. They had lower viral loads, especially when started early. And because we're in the setting of a pandemic, that was good enough information for the FDA, and they approved compassionate use with remdesivir starting in late January. Essentially, eligibility was anyone who tested positive for COVID, who were hypoxic on room air. They excluded patients with kind of severe kidney dysfunction and hepatitis. And this was published in April. They did a cohort analysis of 53 patients who did receive remdesivir under compassionate use, and 68% of them were observed to have a clinical improvement. For what it's worth, the takeaway from this is, again, that we need randomized placebo-controlled trials to really know whether remdesivir works. And sure enough, that's what we got. Sometime in May, this was published in the New England Journal as part of the ACT-1 trial, stands for the Adaptive COVID-19 Treatment Trial. Just a quick side note on adaptive trial designs. It's actually a fairly new concept. It came about around 2012. It allows for modifications to the trial and the stats procedures after the initiation of the trial. The idea is that it keeps it flexible and efficient without compromising the integrity of the data. And so ACT-1, it was a multi-center, double-blind, randomized, placebo-controlled trial. They included 73 sites actually around the world. Still about 80% were from North America. They enrolled a little over 1,000 patients, essentially adult hospitalized patients with COVID evidence of pneumonia. And the exclusion criteria was very similar to that of the compassionate use criteria. The primary outcome was time to recovery. And interestingly, that was actually one of the things that was changed after they had already enrolled about 100 patients. They initially had outcome at day 15 as the primary outcome. But as we were getting to know more about COVID, we know that patients have this protracted course of disease. So the studiers did not want to set it at day 15 and then not see a difference at that point. So they made that one of the secondary outcomes. And here it was a 1-to-1 randomized, and this is the dosing regimen for remdesivir. They studied a 10-day course. Safety was pretty well tolerated. Thought it was interesting. It was the same number of patients in the placebo arm that had adverse events as the study arm. And actually, ultimately, the study was stopped early. The Data Safety Monitoring Board reviewed their interim analysis on April 27th, and they actually had more than the estimated number of recoveries needed for the trial. And so the results were made public just a couple days later. And what they found was that the median time to recovery was significantly better in the remdesivir arm. It was 11 days versus 15 days. And here is actually a subgroup analysis looking at of the patients who were receiving oxygen. They had the biggest separation in the curve, so it even more dramatically favored remdesivir. And the 14-day mortality was actually also better in the remdesivir arm, but it just wasn't quite statistically significant. And it's ironic because they changed the primary outcome, but they were actually able to find a difference in effect within 15 days. And the adverse events were actually comparable. In fact, they had more in the placebo group than the study group. And so the authors concluded that remdesivir was superior to placebo in shortening the time to recovery. A couple of caveats, the biggest being analysis is still ongoing. We don't have the 28-day data yet. Another thing I wanted to call your attention to was a different kind of subgroup analysis that they did. They separated the patients out based on their baseline ordinal score. And as you remember, score of 7 are those who are intubated or requiring ECMO. And it actually seems like in that group of patients, maybe remdesivir didn't quite help, and maybe actually their outcomes favored the placebo group. Obviously, this is too premature to draw any conclusions, but this does help shape some of our later guidelines, which I'll mention. And then there was another study that came out looking at 5 versus 10-day course of remdesivir, and they showed no difference. So based on all of this, on May 1st, the FDA issued an emergency use authorization. At that time, much of the drug was actually donated by Gilead, and the access was allocated by the Human Health Services and State Department of Health. I put an asterisk there because was a lot of complications surrounding the distribution of the drug, and it was very politicized at that time. It is one of the 3 ways to obtain the drug, and it's actually currently the only way to obtain the drug here in Hawaii. The other 2 ways are through a clinical trial, which are no longer enrolling, and then through compassionate use for pregnant patients and pediatric patients. And actually, currently, the drug is no longer free, so our hospitals are having to purchase them, and the distribution throughout Hawaii is managed by a center, kind of a central figure in Hawaii Healthcare Emergency Management. Gilead did sign some deals with generic makers to make the drug available in multiple countries. And you've probably heard about this in the news, but we have been dealing with supply issues with remdesivir for a while. Just about anybody who was admitted received the drug. And now because of the limited supply, NIH actually came out with some use guidelines. They recommend that we prioritize hospitalized patients who are hypoxic but not intubated. And that's actually based on that subgroup analysis that I mentioned earlier. And we follow the same guidelines here at Queens, and everyone gets a 5-day course. Okay, so moving on to dexamethasone. I titled this kind of the pendulum of steroid use that likes to swing back and forth. So from my kind of home care perspective, we really do have a love-hate relationship with steroids. We know that it works for a lot of indications, asthma, COPD exacerbations, certain forms of shock, laryngeal edema, a lot of CNS indications. But we also know that when it comes to lung infections and steroids, it's a lot more controversial. And I think the guidelines kind of swing back and forth every few years. As of now, steroids are not routinely recommended in community-acquired pneumonia, influenza, other viral pneumonias. We sort of just extrapolate data from the flu. What we do know that it's really not benign, and this is looking at steroids in flu pneumonia. This was a meta-analysis published in 2016. And overall, you can actually see up top here is mortality. This is ICU length of stay, and this is secondary infections. And it seems to all actually favor the control group. Some other data we have, this is actually looking in the first SARS outbreak. This was, I believe, published in 2014. The primary endpoint here is viral titers. This is over time on the x-axis. This blue line here is the control group. The pink line is the group that received steroids, initially hydrocort and then methylpred. And you can see overall, the steroid group had much higher viral titers throughout their disease course. It did not necessarily lead to worsening outcomes, so I'm not sure if that's clinically significant, but there is always this concern that steroids can decrease viral clearance. This chart over here on the right was from a large SARS database that was analyzed in China. They looked at survival based on the dose of steroids. They looked at methylpred. This is black line here is the control group, no steroids. You can see the green and the red lines clearly did worse. This was much higher doses of steroids. But here is methylpred 80 is the blue line. and maybe they actually had a better outcome than the control group. This was retrospective. Of course, they actually had incomplete follow-up for the control group. And the difference actually wasn't seen until like over day 50. So a long time after the administration of steroids. So it's hard to say if that's really what caused the difference. But nonetheless, it makes us think that maybe there is some reason to look into steroids and COVID. Some of the early data, they're not robust, single center retrospective stuff, but they did show that maybe using methylpred for 5 to 7 days shortened the oxygen requirement, 8 days versus 13 days. Another retrospective study actually found maybe a potentially mortality benefit published in JAMA. And then in April, the study came out looking at hydrocortisone, and they actually did not see a difference in viral clearance. So mostly the thought process has been, well, it's about the timing of the steroids and the dosing of the steroids. And this is sort of what we understand for the COVID, evolution of COVID disease. We know this initial viral phase, probably too early to give steroids, may decrease viral clearance. And then we have this host inflammatory delayed phase, probably by then too late to be giving steroids. But maybe there's this sweet spot in the middle between week 1 and 2 of their symptom onset. Maybe that's the perfect time to give steroids. Well, the best study we have so far about steroids in COVID is this one. It's the recovery trial that was published, I believe, also in May. Recovery was also a similar network trial, kind of like the Solidarity trial run by the WHO. It's a controlled open label trial to study a number of different potential therapies. Dexamethasone is one of them. They included 176 different hospital systems throughout the UK. They enrolled a little over 2,000 patients. Interestingly, they were either lab confirmed or suspected cases of COVID. So about 10% of them actually ended up being COVID negative. And then their exclusion criteria was that if they did not have dexamethasone available, or if the patient was not considered suitable for randomization. And that was sort of at the clinical discretion of the attending physician. So that inherently probably introduced some bias into the study. They randomized them 1 to 2, looking at dexamethasone 6 milligrams daily. That's the equivalent of about 40 milligrams of prednisone versus usual care. They looked at 28-day mortality and a number of secondary outcomes. Results-wise, seemed promising. Lower mortality, for all comers, lower mortality in dexamethasone arm. Then they did a number of subgroup analysis. Here, it seems like the biggest benefit was in those who were intubated. There still was a benefit in those receiving oxygen. But then in the patients who did not require supplemental oxygen, actually looks like the line for dexamethasone, it had a higher mortality in that group. So it may actually do some harm in those patients on room air. Another subgroup analysis they did was looking at days since symptom onset. So those who had symptoms for less than 7 days didn't make much of a difference. But maybe those who had longer symptoms, more than 7 days since symptom onset, they seem to do better. The dexamethasone arm seemed to have done better. So again, maybe we're tapping into the timing of when we should be giving steroids. The suspicion is that those with longer symptoms, those who are already intubated or needing more oxygen, that they are much more hyperinflamed, and maybe that's where the benefit comes from. So overall, it's a good study. It's large, it's pragmatic, but it has its limitations. The biggest criticism has been that the enrollment bias. Overall, they excluded about 17% of these patients, and it was unclear to the reasons why, so it's hard to say if that can skew their data one way or the other. Otherwise, it's not blinded. They didn't control for the duration of symptoms onset. And also, they didn't really have specifics about the oxygen requirements or the adverse events. Those are all things that we would like to know. So what do we do about dexamethasone? Even the society guidelines are mixed. The NIH does recommend dex for patients who are on oxygen. The Society for Critical Care Medicine recommends dexamethasone only if they also meet criteria for early and moderate severe ARDS. That's also based on some ARDS studies that we have that shows steroids may work early, and those patients are intubated, which is the group that benefited the most out of the recovery trial. And then the American Thoracic Society was just pretty vague. This didn't really have recommendations for or against steroids. So what are we doing here at Queen's? If they have an indication for steroids, we do recommend to go ahead and use it. Otherwise, we're restricting it to inpatients who also meet sort of a certain degree of hypoxia. And we're being pretty aggressive with treating their hyperglycemia. We've already had a couple of patients go into TKA, and we are screening them for strongyloides. We do have a population who are at higher risk for hyperinfections. Okay, so moving on to convalescent plasma. I titled this The Resurrection of Convalescent Plasma. So where does plasma come from? So if you take a donor and you take their whole blood, you spin it down in the centrifuge. The blood cells on the bottom are the red cells, the platelets, and then what's on top is the water with proteins, which includes the antibodies. And that's the part that we are donating to the sick patients, and then we give back IV fluids to replace the plasma volume that you took from the donor. This whole concept of convalescent plasma borrowing serum from a recovered patient to give to a sick patient is not at all new. It actually dates back to the late 1800s, beginning of 1901, beginning of 1900s. Dr. von Behring actually discovered the diphtheria antitoxin, and he injected into sick patients and cured them. This was the very beginning of passive immunization, and he actually won the first Nobel Prize in Physiology and Medicine for his work. This was again used in the 1918 Spanish flu pandemic. In the 1930s, it was used for measles and mumps. There was a hantavirus outbreak actually during the Korean War in the 1950s, and the US Army used convalescent plasma. And then more recently, for all of the respiratory virus outbreaks, SARS, H1N1, MERS, and even Ebola. The best data that we had up until this point was a meta-analysis that was published in 2015. They were looking at convalescent plasma for SARS and severe influenza, and they combined a number of very heterogeneous studies, but overall they did show a protective effect. They showed that it worked best if we were to give it early, and it was pretty well tolerated. There were some transfusion-related reactions. Some argue that it may attenuate innate immunity, but overall it seems like a safe therapy to give. So it made a lot of sense to try to do this for COVID-19. If we have a recovered COVID-19 patient, we take their plasma, we do an ABO matching, and then donate it to a sick COVID-19 patient who hasn't had the chance to create any antibodies just yet. Of all the data that's out there so far, the most robust is this randomized clinical trial. This is the first RCT for plasma, actually, and they were actually able to document the antibody titers for all the donors, which is the first time that that's been done. It's open label, multi-center, randomized. It was done in 7 centers in Wuhan, China. Of the 100 patients that they enrolled, they actually divided them into severe, which is that they're hypoxic, or life-threatening, essentially if they're intubated, in shock, or has other organ failures. Pretty standard exclusion criteria. They did exclude the super duper sick ones, so severe septic shock, PF ratio less than 100, so very, very hypoxic patients, they excluded them. Their primary outcome was time to clinical improvement within 28 days using that ordinal scale. The trial was actually stopped early because the outbreak resolved, so they were only able to enroll about half of what their target patient numbers were. But overall, they said there was no difference in mortality or time to discharge. But they did separate it out based on the subgroup analysis, and it actually shows that maybe in that severe population, not life-threatening, convalescent plasma maybe had a beneficial effect. They were also able to show actually that the plasma group had higher rates of negative viral PCRs. So they were arguing that maybe there's some antiviral activity going on with the higher titer antibodies. Since then, we've had some positive data come out. This was just last month. They published a meta-analysis of 12 studies, a little over 800 patients. They simply combined the case fatality rates from all these studies, and they showed that there was a mortality benefit. In fact, there was about a 50% decrease in mortality. Of course, they combined heterogeneous data. This is retrospective, but overall it is promising. And the first author on this study, Dr. Michael Joyner, he's actually a Mayo Clinic doc, and he runs the nationwide IRB for the Expanded Access Program for getting convalescent plasma for COVID patients. And here at Queens, we are a registered site, and some of us docs are registered to consent our patients. And the process is very simple, actually. If they meet inclusion criteria, which is just about anybody who's symptomatic and hospitalized, and they sign the informed consent form, then we do a blood type and we wait for an ABO matched donor. It's about 100 cc's of plasma that we give them. We do have a protocol shortage currently, so we're prioritizing those with kind of shorter symptom onset with rapid worsening, trying to give it as early as we can in their disease course. This is Mr. Nua. He is actually our first COVID patient to have received convalescent plasma. He did have a very complicated hospital course, including ECMO, but he was successfully discharged, and Star Advertiser interviewed him. It's hard to say if the plasma was necessarily the one thing that made him better, but it's always good to see our patients have good outcomes. Okay, last but not least, tocilizumab. Rationale. So it is a monoclonal antibody. It targets it actually blocks IL-6 receptors, and it blocks a number of downstream signaling pathways that overall is anti-inflammatory. It dampens fevers, it decreases the acute phase response, it decreases the production of neutrophils, etc. So it's FDA approved for autoimmune conditions like rheumatoid arthritis and juvenile idiopathic arthritis. And it's actually the first monoclonal antibody to be approved for cytokine release syndrome associated with CAR T cell therapy for some cancer patients. So why are we trying it out in COVID? Well, for one, the good news is that we know the drug is fairly well tolerated. Some of the adverse effects, injection site reactions, it can cause hepatitis. It can reactivate latent TB. And because we're knocking down their immune system, if they have a secondary bacterial or fungal infection, it could make that worse. But overall, a well-tolerated drug. We also know that COVID patients get ARDS, and we know in ARDS literature that they can have elevated inflammatory markers, and that's associated with increased mortality. We also know in the really, really sick, critical and fatal COVID patients, they get these high inflammatory markers and they have a cytokine profile that's very similar to cytokine release syndrome. So it would make sense to try a drug that's worked for CRS in a different situation. Overall, the data is limited. That's sort of the theme of this talk. Most of the evidence we have thus far are single-arm observational studies or retrospective analysis. Just in the interest of time, I won't go through the details about all of these, but I included a few. These are all pilot studies coming out of mostly Italy and China. It showed that it seemed to work, but didn't have much of a control arm to compare it to. There are a number of active phase 3 randomized control trials ongoing. The biggest one that you may have heard about is COVACTA up here. It's sponsored by Roche. They are looking at the ordinal scale as an endpoint. A couple more that's sponsored by Genentech. They are looking at event days at 28 days. And this one out of MGH is actually placebo-controlled, but 2-to-1 randomization scheme. And this one is coming out of Emory and sponsored by the National Cancer Institute. It's open label. They use a little bit of a different dosing regimen, and they're looking at event days and 30-day mortality. So far, we don't have much data. Just a couple of weeks ago, Roche actually gave us a COVACTA trial update. It was their 4-week interim analysis. Unfortunately, they did not meet primary or key secondary endpoint just yet. The primary endpoint is that ordinal scale, no difference between the two groups. Mortality is pretty much identical between the two groups, but there was a positive trend in time to hospital discharge that favored tocilizumab, 20 days versus 28 days. And they did not see any kind of new safety signals, no new safety concerns. So that's always reassuring. And then this was actually just a few days ago. This was published in Lancet Rheumatology. It's an Italy group. They did a retrospective cohort study of a little over 1,000 patients. All of them received standard therapy, which to them included azithromycin, hydroxychloroquine, and antiretrovirals. And then they took a subgroup of them and gave them tocilizumab on top of their standard therapies. And their composite outcome was the risk of death or need for vent. And actually, it did seem like the tocilizumab group had better outcomes. And I'll just focus on this panel right here. They adjusted for sex, age, and SOFA score, so their disease severity, and they actually looked at just death alone, and it did seem like there was a pretty dramatic effect. The red arm is the placebo, and the blue is the toci group. So not perfect retrospective, but maybe some promising data. And what's going on here at Queens? Well, we have our own tocilizumab trial. The abbreviation is ARCHITECTS. It is randomized placebo-controlled. Our inclusion criteria, we included all adult patients hospitalized with COVID pneumonia. They have to have at least one lab marker indicating that they have hyperinflammation, so either IL-6, CRP, or ferritin levels. And then they have to have one kind of clinical marker showing that they're worsening. Either they're getting intubated, very hypoxic, in shock, or requiring ECMO. The exclusion criteria is pretty standard, so excluding them if they already have hepatitis or if they're already immunosuppressed. Of course, if they have a suspected active bacterial, fungal infection or active TB, and not participating in any other particular drug trial. This is just a protocol kind of guiding us of what we're doing with these patients. Just want to highlight that we are checking quantiferin gold on all of them, and if we find latent TB, we would treat them, and we follow them through for 28 days. We've enrolled just short of 20 patients thus far, and again, this protocol is standardized to a lot of the other trials. So hopefully we'll be able to add our information into other bigger trials as well for analysis. Okay, so sorry, that's like a whirlwind of information. In summary, we currently, unfortunately, still don't have any FDA-approved drugs to treat COVID-19. Remdesivir is the only one that's available through the emergency use authorization. I hope I've convinced all of you that off-label therapies really should be used within the context of a clinical trial. It's really worthwhile to study them appropriately in order for us to get to the answers. And responsible research really does need the support of the entire medical community. Future directions, lots of exciting things, also confusing things going on. There's a number of outpatient studies that are taking place looking at the milder outpatient COVID patients. There are a number of adaptive trials looking at a combination of drug therapies to see what works. I'll be honest, most of our inpatients now have been enrolled in at least one of these studies and probably have received most of them. It's going to be a little bit of a statistical nightmare to figure out exactly what's working and what is not. And of course, I'm sure we'll hear more about this in the news of the development of vaccines and testing of vaccines. This is a therapy one-pager that I made and have been updating that we're distributing to all of our inpatient providers. It's a quick summary of the 5 big kind of categories of drugs that I mentioned, inclusion, exclusion, and some kind of tidbits to know when it comes to clinical practice, who can come and consent, etc. Include that here for you guys if you're interested. And finally, just thank yous. Big thank you to of course, our big, awesome research team, the hospital administration that's been very supportive of what we do, my ICU colleagues, our COVID hospitalists, all the nurses and staff, and of course, the patients and their families for letting us take care of them and for participating in our trials. And this is my dog. His name is ECMO. I put him on all my slides. And any questions?
Dr. Go, that was a wonderful presentation. Thank you so much. For the audience, if you have any questions, could you please type them into the chat box? While I'm waiting for people to type in their questions, Dr. Go, I just have a question about the current status of COVID in Hawaii.
Yeah. Well, the numbers, as I'm sure you guys have seen, have been going up and up and up. A lot of it is a community spread. A lot of it has been gatherings and kind of multi-generational families who live in one place and they're not able to social distance. Our ICUs are kind of over capacity and we're leaking into the surgical ICU and the neuro ICU, and those colleagues are helping us out taking care of these patients, but we're definitely very much in a surge and very much in need of flattening of the curve again, unfortunately.
Thank you very much. And thank you for what you're doing clinically, you and your colleagues every day for us.
Of course.
Does anyone have any questions? Please type them in the chat box. That was certainly a very comprehensive review that you gave us.
Yep, and I'm sure
the data.
Things will be changing. Unfortunately, we don't have great data for a lot of the things that we do. I think that the best that we can do is try to stick to the evidence that we have, try to stick to what we know to be safe and in the best interest of the patients, and then just kind of following up on the updates as we go and do the best that we can.
Yeah, that's all we can all do, I guess. Thank you.
Yeah.
Well, I'm going to wait 1 more minute for questions. If there are no questions, then we'll sign off, but I just want to give people a little bit more time. Okay, so one question is, how do you decide which drug to try?
Yes, that's a great question. So essentially we are basing it on the kind of quality of evidence that we have. I will say that the priority is given to remdesivir because it is FDA approved for emergency use. And so essentially any patient that's coming in through the ER confirmed COVID, we consult our COVID infectious disease doc and they help us out with the inclusion and exclusion criteria. Just about anybody who is at least on oxygen and they don't have a liver problem and they're not end-stage kidney disease, they will qualify for remdesivir. And so they will go ahead and start that, and that's a 5-day course. So that takes priority. And then convalescent plasma is the other one that has somewhat good data and very little side effects. So that's the kind of second line. We are consenting just about all of them for convalescent plasma, a little bit limited by supply. So those two things, just about all of our inpatients will get unless they have a contraindication. Steroids is something that nowadays we are adapting, that if they are hypoxic to a certain degree, then we kind of evaluate them from a POEM perspective. We get consulted POEM care, and we, along with the hospitalist, decide if they will go ahead and get the dexamethasone if they don't have any absolute contraindications. And then I think the last would be the tocilizumab, because that, for one, is for the really, really sick, in shock, intubated patients. And two, we do need some time to make sure that they don't have any secondary bacterial or fungal infections. So it kind of goes in that order. Remdesivir convalescent plasma, just about everyone gets. Dexamethasone is a pulmonary critical care evaluation, and then tocilizumab is a couple days into the disease course, see how they do kind of evaluation.
Thank you, Dr. Gore. The next question is, has there been any thinking about rationing of medications?
Lots, actually. So I am part of this off-label drug advisory group. I'm part of a hospital. It's led by Dr. Todd Sito. He's our director of medical research. And we have our pharmacists and research nurses, and they are constantly every day being updated about the supply. The biggest problem is remdesivir. And we are having to make those tough decisions, unfortunately. We are saying, is this patient really going to benefit? Has it been too long into their disease course? Maybe they won't benefit. So we are actually having to ration the drug supply even every day in our Tiger Text groups.
That must be a very difficult decision, I'm sure.
Yeah.
Another question is, are all the hospitalized patients being proned?
Oh, that's a good question. Yeah, I didn't get into, because mostly we're talking about kind of drug therapies, but I'll put a plug in for self-proning. So what we do know, so, back in the day, we have data in bad ARDS, really hypoxic respiratory failure. If we prone them, you're improving VQ mismatching and improving the kind of distribution of their blood flow, and then it improves their hypoxia. So we know that. Now we are finding out that in COVID patients, even early on, so they're not intubated yet, they're on tower 9, they're talking, they're just on oxygen. If we can get them to self-prone, so literally just telling them to turn over and lie on their stomachs, that can improve their oxygenation and improve kind of the distribution of blood flow in their lungs. So absolutely, we actually just came out with a protocol. We're basing it off of the UCSD protocol. Every admitted patient, if they're on oxygen and they can follow commands, we'll talk to them about how to do it. It's at least 2 hours. We prefer 4 hours at a time on their stomach. And we're doing that throughout the day. We're asking them to do it themselves.
That's very helpful. The next question is, what are the discharge criteria for COVID-19 patients at Queens?
Oh, that's a great question. It is constantly changing. I will not be the best person to ask. Dr. Bello in our infection control group is in charge of that. And unfortunately, because I work in the ICU, we are not really discharging anybody directly from the ICU, so I don't have as much experience. But I know that we are, at least as of last week, we're talking, they have to have at least 2 separate negative COVID tests, at least, I believe, 8 hours apart. And they have to have like a certain type of kind of no longer having fevers and other kind of concerning infection symptoms. But the last I checked is that they have to have 2 back-to-back negative COVID swabs.
Thank you.
This is, I should say, sorry, I should say that is for going to a nursing home, going into another facility. For our patients who are going home and they're able to self-quarantine, it's a little bit less stringent, of course. But then they need to kind of essentially keep them in their homes until they're entirely symptom-free.
Okay, thank you very much. One last chance for questions, anyone? Okay, well, that was a very comprehensive review, Dr. Goel. Thank you so much. There are several comments about how wonderful your presentation was, and I certainly enjoyed it as well. So thank you all for attending our grand rounds, and a special thank you for Dr. Goel for the wonderful work that she does with the COVID patients and for presenting for us today.
Yeah, thanks so much. Thanks for having me.
Okay, bye-bye.
Bye.